All right. So, IV fluid. We all give IV fluid relatively frequently, right? What are you doing? You're giving some sort of thing that is not normally in your body, and you're putting it in through a vein. And the idea is you're going to bulk up the volume of blood that's circulating around in your body. So normally we would kind of think, well, maybe the best resuscitation fluid that we've got, if we need to give something to replace volume in our vascular space, is blood, right? Sort of makes sense. Now, not everybody needs blood all the time. Sometimes fluid will work. You don't necessarily need a whole bunch more red cells all the time or clotting factors all the time. Sometimes you do, but for the most part, a lot of people will do kind of okay, and that's a kind of, with just IV fluid itself. Stuff that is not blood, just a liquid in there to sort of bulk up volume. Now, that's not ideal all the time, and folks again say that the ideal resuscitation fluid is blood itself, because if you need volume, just put blood back in there. You're not leaking, out of your amputated arm, you're not leaking saline, you're leaking blood. So just replace it with blood or a blood product. And that's sort of true, but the problem with blood is that it's expensive, it requires close monitoring, the blood banks are like real cautious about it, and it's hard to get that from an EMS service, so almost nobody carries actual blood or blood products outside of like some air services where they got money and they don't do a whole lot of runs, and it's not sitting in an ambulance all day out in the sun or anything like that. They have a lot more control over it. So blood and blood has not zero risk either. Our blood supply is pretty safe, but folks still get diseases from their blood transfusion, and folks still have reactions to blood and blood products, transfusion reactions. So the risk of giving somebody blood is not zero either. So we tend to give fluid, and again, who do we give fluid to? Usually, it's the people that seem to be in shock or close to shock, or need some sort of replacement of their volume. Somebody that's in bad sepsis that has a lot of vasodilation, so all their blood vessels are super huge, and you just gotta fill up the tank with something. Or the guy that's bleeding, that's lost all his blood volume on the street. Or the guys that sometimes in like cardiogenic shock that we're just trying to replete them and get them back up to on that Frank Starling curve so that their heart beats more efficiently. So there's lots of reasons we can give people some type of fluid. Again, theoretically, the ideal resuscitation fluid is the patient's own blood. Blood itself is awfully expensive and a little bit dangerous and a little bit hard to use, so we're not going to do that. Long story short, we are going to be given some kind of IV fluid that is not blood, probably, for the foreseeable future in the pre-hospital setting, just from our constraints. And we give it in the emergency department. It's not like we're going to get away from it anytime soon. So, what type of fluid should we be using? Well, now there's a couple of different things. If you're not going to use blood, you've got basically kind of two choices about what you might use. There's things called crystalloids and things called colloids. We use mostly crystalloids, and we use generally speaking, isotonic solutions. What I mean is that if you look back at the history of when people started doing IV fluid, they first started, the guy injected like 6 ounces of water intravascularly into somebody's blood vessels. And then they started putting some other stuff in with the IV fluid. The problem is that if you just put water in, regular old sterile water, let's say, you get problems with the tonicity of it. So these are red cells floating around in, right now this is started with an isotonic solution, now it's a hypertonic solution, meaning that there are more dissolved things in the, in the fluid than there are in the cells themselves. And if you kind of watch, I'll start it again here. Here's what the normal cells look like. They get plopped into a hypertonic solution. If you watch those ones down at the bottom, you see they kind of shrivel up a little bit. That's because the water tries to pass outside from the inside of the cell to the outside of the cell and follows a concentration gradient. That's the basic kind of high school chemistry stuff. Water follows whatever concentration gradient there is. The same thing happens if you use a hypotonic solution. So if you take the cells, you watch them down at the bottom, you'll see they get bigger and bigger and bigger. What's happening is because they have more salt and more solute inside there, they are swelling. And then give them just a second. Here comes the big part. And watch that guy on the right. There he goes. they get so filled with water that they burst. And so that's what happens if you put a cell in a solution that is less concentrated than the stuff that it's used to. So isotonic solutions are important. That's why we tend not to give things like just water. It's got to have some salts and stuff dissolved in it, and some sugars and that sort of thing dissolved in it. Going back to the idea of like you have the crystalloids and you have the colloids. Colloids are like big molecules like starches, and crystalloids are basically salt water. So if you think of it as the stuff that you have before you put the spaghetti in, when you just got a pot of water boiling on the stove with some salt in it, that's crystalloid. After the spaghetti's been in it and you drain it out and it leaves that like yellowy kind of slightly thicker water, that's a colloid. And that's actually a pretty good analogy for what crystalloids and colloids are. We don't give colloids anymore, really, because they are expensive and found to be sort of inferior in terms of they require you to get more blood transfusions if you need volume, and they don't and they increase the risk of bad things happening. So we don't really give colloids anymore. We give essentially just crystalloids right now. Crystalloids can further be divided into a couple of different kinds, and this is where we get to the point where you can start caring about what I'm about to say. So, two flavors of crystalloid. There's sodium chloride, normal saline, which is 0.9%, and then there is the balanced salt solutions like lactated Ringer solution, plasmolite, Ringer's acetate, that sort of stuff. The difference is in their composition itself. So 0.9% sodium chloride or normal saline just has salt in it, sodium and chloride and water. Lactated Ringers and all these other solutions have different things in them, like lactate, like acetate, like calcium and magnesium and potassium and that kind of stuff, depending on the type of solution. And that's really the difference between the two of them. And what we have always heard was that basically these are the same. It doesn't really matter what you use. Folks, the trauma guys have always pushed for like, oh, you should be using LR, we should never use saline in a trauma patient. But there hadn't really been evidence until recently that it really makes a difference at all. That you could give, as long as you give some sort of mostly isotonic solution, for generally speaking, that people do the same. They have the same outcomes, and clinically it doesn't make any big difference. This is my statement right now. I think that as a relatively mature provider, that there is no good reason to use lactated Ringer solution, and there are several good reasons not to use normal saline. We'll mostly talk about those first. Here's some of that stuff. Number one, normal saline is not normal. The name normal saline was coined when they said, well, this is physiologic. This is the normal stuff that's floating around inside your body. This looks like the liquid concentration of your blood. And it's true that is close in terms of the number of particles and the sodium concentration in your body, but by no means is it what is actually floating around in your blood vessels. Here's kind of a diagram. It's a little bit busy. We'll walk through it for just a second. If you look at the top bar up there, you see this is the concentration of solutes in serum. So you have about 140 milliequivalents of sodium, about 4 milliequivalents of millimoles of potassium, about 100 millimoles per liter of chloride, and somewhere around 9 of calcium and 2 of potassium, thereabouts. Or not potassium, magnesium, sorry. So 140 millimoles of sodium, 4 of potassium, 100 of chloride, 9 or so of calcium, and 2 of magnesium. That's what normal electrolytes look like. If you look at the resuscitation fluids down below there, basically the bar that looks the closest to the one at the top is the one that most clearly approximates what's in your serum. So LR looks pretty close to it. It's got a little bit less sodium sometimes, but not that much. It's got a little, just tiny bit more chloride and a bit less calcium, and about the same amount of potassium. Saline, though, is markedly different, right? If you look at the bar at the third bar down, it looks nothing like the bar at the top. So just call it normal saline is not really accurate. The saline bar, that dark blue part, looks maybe about the same, but it's really not close at all. Those two look remarkably different. So to call it normal saline and say that this is something that is physiologic is just not true. It's just not there. Why does that make a difference? Well, when you give somebody something that's not there or that's not normal, not what they're physiologically used to, you make changes. And the problem with giving somebody normal saline is that it makes your blood more acidic, among other things. Makes your blood lower down on the pH scale, gives you more acid in your blood, if you want to think of it that way. If you look at standard chemistry, they give you the pH scale and they say, here are the things that fall in each category. A pH of 7 is supposed to be deionized water, like water is supposed to be neutral. If you look at normal saline, it is right here and falls at a pH of about 5.4. Now, the reason for that is mostly because it picks up carbon dioxide out of the air. Any aqueous solution, any water solution that you leave out, because it's existing in this atmosphere of oxygen and nitrogen and carbon dioxide, it's going to soak up, it's going to dissolve carbon dioxide. The carbon dioxide actually dissociates and causes it to become acidic. So even things like rain or a cup of tap water that you just set down will become slightly acidic at, again, that same pH. So you may say that, like, well, the reason for the the acidification of your blood, the dropping of your pH of your blood, the metabolic acidosis that happens with the sodium chloride, maybe that's due to the pH of the solution itself because it's acidic and it doesn't have a buffer in it to keep that from happening. And that's actually not the case. The problem is the composition of the fluid itself. While it is slightly acidic, the problem is more what the thing is made of and what we're actually giving the patient. It's actually the medicine or the fluid itself. Here's why, real quick. Bear with me. This is kind of like high school chemistry. But you start off when you take a vat of sterile water and you toss in some salt, some sodium chloride. The salt dissolves out and you get a solution of water with equal numbers of sodium and chlorides. So for every sodium you throw in and every chloride you throw in, you get a sodium 1 to 1 to 1 to 1 to 1. And that keeps all the charges balanced, because if you remember, the one thing nature needs is for everything to get balanced out. Charges, all that stuff, concentration gradients, they need to follow along. They need to stay balanced. And if there's not a balance, then there's a force that tries to make it balanced. So when you, again, take that sodium chloride, you toss it in a vat of water, you get equal particles of sodium and chloride. That's in just a tub of water, though. That's not in your body itself. The interesting thing is that in your body, those charges between the sodium and the chloride are not balanced. They are, broadly speaking, favored toward the sodium side, so a little more pluses, and then you have fewer minuses over on this side, but there are other minuses that your body also contains that take up the broad category of other stuff that help to balance those charges out. So you don't have as much chloride in your body as you do sodium, but you do have some other less strong negative charges in there that will help to balance things out. Hopefully that sort of makes sense thus far. That's just the way that we exist. Again, when you toss some sodium chloride into your body, though, it has balanced charges, but when you toss that into your blood, that requires you to have unbalanced charges of sodium and chloride in order to maintain homeostasis because of all the other stuff that has to happen in your body. You then throw in a bunch of extra chloride, and now everything gets weighted toward the negative side, and your body has to get rid of that, and chemical changes have to occur in order to get rid of those negative charges. And so what happens is you lose things in that other stuff category, such as bicarbonate, which your kidneys then excrete, and that means you don't have as many bases in your blood, and so you become more acidic just because you're balancing charges out. It's not that you're giving the person acid, it's that you're doing stuff to mess around with the electrical potential of your body, and your body has to compensate for that. So you get more pluses, which come in the form of like hydrogen ions, which is acid, basically. Okay, that's the chemistry behind it. Again, so what, who cares? This could be just a lab value. If, I take the temperature of one hose on the manifold of the engine underneath the hood of the ambulance and say, well, this is 150 degrees. Does that really make a difference. Like, who knows? Yes, that is a true finding. Does it actually make a difference to the performance of the ambulance or to the performance of the engine? Same thing here. Does that little drop in pH make a difference in terms of the performance of the body? And you find that, number one, yes, it does. Number two, it's most pronounced in folks that are sicker. And number three, that it is most pronounced in folks who get more fluid. So I won't get into the details of this paper because I kind of hate when people do that. Long story short, there were two papers that came out in 2018. That's when it was. Basically looking at what happened if you used either just saline or just LR in your patients, and they did that for a month. They said, like, all right, everybody that comes into the ICU, everybody that comes into the ED, for this month you're going to get just saline, for this month they're going to get just LR. What's the survival like? And they randomized it, and so it's a pretty decent study in decently large amounts of patients. What they found was that whether you are critically ill or whether you are not critically ill but admitted to the hospital, that you had fewer major adverse kidney events if you got LR or a balanced salt solution rather than normal saline. And what's a major adverse kidney event? It's a combination of dialysis, a change in your creatinine, basically a doubling of your creatinine or a halving of your renal function, or death. And those are three somewhat important things to know about. And the difference was about 1%, whether you're critically ill or not, overall. But again, it's more pronounced if you were sicker or if you got more IV fluid one way or the other. Those differences are bigger. So overall, a 1% difference in the chance that you get worsening kidney function, dialysis, or death if you just switch from saline to LR. The kicker to it seems to be that saline seems to make you a little bit sicker, and using one of these solutions rather than saline, overall, if you do the math and figure out the number needed to treat or the number needed to harm, you treat 94 patients. If you switch over, 94 of those patients will be the same, but then one will have less injury, will not have one of those major adverse events. The number needed to treat is 94 patients. And you say, well, that's not very good. It's only a 1% difference. Who cares? Let's just keep doing what we're doing. It is a relatively small difference, although it seems to actually be there. The thing is that if you think about the number of people that get IV fluid in the hospital and in the pre-hospital setting, you know, we gave 94 patients just in Owen County in a relatively small service. We gave probably 94 patients fluid of some kind last month. And certainly you've seen that many people before. You can prevent one of those people from going on to dialysis, dying, or having a significantly worse kidney injury. Just by changing around what solution we use. And if you extrapolate that across the country, if we start doing this overall, then that number goes up to, we're talking about like 10,000 patients a year, 20,000 patients a year that either don't die, don't go on dialysis, or don't get bad kidney injury as a result. So, yes, small number individually, big numbers when you look at it at the number of people that actually get fluids. The thing is, too, that there's really not a disease state that lactated ringers isn't a little bit better with. There's always concern about, like, well, what about in folks that are hyperkalemic, that have an elevated potassium? We're giving a potassium solution. Isn't that bad? What about, like, the head-injured folks? What about X, Y, or Z? There really is not a disease state that LR isn't a little bit better with. If you look at this graph, this is from the same series of studies. You may not look at these these types of graph, but basically there's a line in the center that says there's no difference between the two. If the little dots here line up on the left side, it says that there's a trend toward things like LR being better, and if they line up on the right side, it says there's a trend toward saline being better. So looking at all the disease states out here, like, what unit did they end up on, trauma, medical, neuro, etc., were they septic, did they have TBI, all that kind of stuff, you find that pretty much everything tends toward the left side, meaning that LR seems to be better in pretty much any disease state. The only time when it's really sort of spread across the two here is in the setting of TBI, but any of these bars that touch that, like, upright bar in the center, means it's not statistically significant, and it's just a little bit on that saline side. So let's look at some of those individual things just to bust it out. Think about it in sepsis. If you have a person that's going to be acidotic from their septic shock, and is vasodilated. LR, lactated ringers, causes less acidosis, or doesn't cause the acidosis that the big chloride-containing solution does, and you have better outcomes, as you saw in that paper specifically. Also causes, saline causes some peripheral vasodilation as well, and you get that less in if you use LR. So in folks that are already vasodilated and already acidotic, we don't want to make them worse, so it's probably a better choice in sepsis. And these folks are going to get lots of fluid, by the way. The septic folks, or presumed septic folks, the essentially guidelines like the surviving sepsis stuff says, oh yeah, they need to get 30 mLs per kilogram of IV fluid, which is a ton of fluid. 3-4 liters, something like that, tons of IV fluid. So they're going to have big effects on it. So better for our septic folks. How about trauma? The trauma guys have been saying it forever that we should be using LR. It again does not cause the acidosis, which is a problem in trauma, because when you have acidosis, you disrupt the clotting cycle, and then when you disrupt the clotting cycle, you bleed more, and you get more cold, and you get more acidotic as you bleed more, and it's this vicious circle, and you just kind of spiral down the drain. So less of that with lactated ringers. You get less disruption in your clotting just outright using LR, and you get that less drop in peripheral venous tone, which again is a big thing. Same thing happens in like GI stuff where you get lots of fluids. It seems to cause less edema in your GI tract. And one thing I didn't mention was that saline itself causes some inflammation in your kidneys and decreases blood flow to the kidneys themselves. So you get overall better stuff when you use LR. Again, pretty much any of these things other than this one little category here, which tends a little bit toward the right side, favor giving, if maybe not statistically significant, but they favor giving balanced salt solution or lactated ringers. So everything's on the side of we should be given this. The one indication where you might say, well, maybe there's time to think about it is in the setting of traumatic brain injury. If you think about what happens when you get a traumatic brain injury, the big thing that everybody worries about and the big thing that kills people is that your brain it either bleeds or it swells, and then it pushes against the skull and essentially like smushes itself, and subsequently you herniate and you stop living at that point, mostly. Or your brain stops living anyway. Your heart may continue on for a little while. But anyway, you go back to what happens if you take a bunch of water and you toss a brain into it. The brain will soak up that water because it's hypertonic inside the area of the brain itself. The brain soaks up that water and goes like a sponge, and you get cerebral edema. So folks always say in TBI and that sort of stuff, avoid hypotonic IV fluids, IV solutions. If you look at the composition of your serum, it's about 285 osms. That's the solute concentration in your serum. Look at lactated ringers, it's just slightly hypotonic at 274. Saline is a little bit hypertonic at 308. And so you may say, well, clearly, if we shouldn't be giving hypotonic solutions, then we would want to give the saline. Well, the problem is, though, that this doesn't exist just in isolation in and of itself. If there was no other problem with giving saline, yes, that makes perfect sense. However, when you think about these guys that have bad traumatic brain injury, they pretty rarely in our setting are an isolated head injury. We are giving them, the reason they get fluid from us should be because they're sick otherwise. They're bleeding, they've got vasodilation, and they're in shock, something like that. So, yes, we shouldn't really be giving folks with an isolated traumatic brain injury a lot of fluid because we shouldn't need to. But if we have to give it to them, then we probably should give the one, in my opinion, the theoretical benefit of a slightly, or the theoretical harm of a slightly hypotonic solution weighed against the acidosis, the coagulopathy, and all the other bad stuff that happens when you give somebody saline, still favors giving them lactated ringers. We kind of got to get out of our minds that giving somebody saline is a benign process, just like giving any kind of IV fluid has its risks with it. But saline is not in itself. It's not that there is no risk when you give somebody saline. You have to balance those out. And in my mind, in the undifferentiated patient that we're seeing in EMS, if we're giving them fluid, whether they have a traumatic brain injury or not, we should be doing it for a good reason, i.e. we need to maintain their perfusion because they're in shock. And if we're doing that, we should just go ahead and give them LR and not worry about it because of the risk-benefit ratio. So I still say, even in traumatic brain injury, let's just give them LR. Let's not worry about it. And they shouldn't be getting the fluid anyway if they didn't absolutely need it. Now, insulin, or sorry, not insulin, the other state that you might kind of think about these folks needing something other than lactated Ringer solution might be, DKA or states where there is known hyperkalemia. So you think about DKA, we always hear about, oh yeah, their potassium goes up initially. And so would it make sense to give somebody who has an elevated potassium a potassium-containing solution? Likewise, if they are in renal failure and their potassium is up, would it be bad to give somebody a solution that contains potassium when they've already got too much potassium? Here's the thing, though. The potassium level in your body when it is elevated is somewhere around like 7 or 8. Let's say that. Let's say your potassium level is 8. The potassium concentration in lactated Ringer solution is 5. So you are giving them you are still going to bring their potassium down just through dilution. If you think you take a solution if you take your blood that's got a potassium level of 8, you take an equal volume of fluid that's got a potassium level of 4, and you smush them together, the overall potassium concentration goes down. The volume doubles, and the potassium concentration goes to 50% of the difference, which is 6. So you still get a lowering of potassium through that dilution. Adding in a potassium-containing solution doesn't actually raise your potassium as long as it's lower than what your blood is, which lactated Ringers would be. But the other thing is that in DKA specifically, the folks would kind of think about or worry about maybe, and even in some other states where your potassium is elevated, the problem usually is not that you just don't have that much potassium float, or that you have too much potassium in your body. The problem usually is that you're acidotic, and that causes potassium to go outside your cells. And so when you fix that acidosis, the potassium goes back in your cells and your potassium gets lower. And that's what you want. That's the big driver of it. And what happens when you give somebody saline? They get more acidotic, and so the potassium goes up, at least to some extent. So theoretically and practically, really, giving something that is balanced like LR, even though it's got a little bit of potassium and doesn't drop the dilution quite as fast as saline might, with no potassium in it, it's still better to give these people a balanced solution like LR, because it fixes their acidosis. And to kind of go along with it too, just as an FYI, most people with DKA are going to get potassium anyway. You start off with giving them some fluid, and then almost all these guys actually have a whole body deficit of potassium. So the next thing after you get their labs back is usually that they get started on some sort of potassium-containing solution anyway. So we can go ahead and just do that. We can give them LR. There's really nobody that you're going to make sicker using the stuff that's in lactated Ringer solution. All right, I've talked a lot. Let's sum up real quick. We're going to have to give something. We are not going to be able to get away from giving some kind of IV fluid for most of our patients in the foreseeable future here, although we don't have to give as much as we need to. Not everybody has to get fluid. Most people don't have to get fluid. Most trauma patients don't need to get any fluid at all. But there are some people that we're going to have to give some fluid to. So we got to pick the stuff that favors the most benefit for the least risk. Normal saline is not normal, and it is not a benign solution. Just giving it because we think, nothing's going to happen, it's just salt water, that is actually not true, and we need to get away from that line of thinking. So saline has some risk to it, and also there's no practical reason that we couldn't give something like lactated Ringers or Plasmolite in EMS to our undifferentiated patients. There's no good reason to not give LR. So what say we just switch and give lactated Ringers to pretty much everybody and forego the risks that we know happen with saline? That's what I got on saline and stuff.